Sort of reminds me of atrial fibrillation. Vocal chaos. So, atrial fibrillation, what to focus for a non-electrophysiologist in 30 minutes. You know how to diagnose it, you know what the ECG looks like. We'll try to go through some concepts and some key places in decision making. I think this is one of the key electrocardiograms of atrial fibrillation. Sometimes it's there, so kind of irregular, and then it goes away. Paroxysmal atrial fibrillation really tells the story of present understanding of atrial fibrillation. It's two diseases rolled into one. One disease is the one that comes and goes. It's all about what's triggering it, what's starting it. And another disease is doesn't matter too much what's starting it, something with the milieu, something with the substrate that once you're in it, it tends to stay. To some extent, a lot of the clinical decision making, especially referring for ablation, has to do with which type of this atrial fibrillation you think you're dealing with. Clinical questions that come up: rhythm control, rate control. So most of this you know, and you know it because of multiple studies from the early days told us, even though you think about the arrhythmia of atrial fibrillation, essentially, if you can control the rates versus attempts, best case, how you can do it for rhythm control, other than symptom improvement in some patients, there's nothing fundamentally better about rhythm control. This is still true today if you just take all comers with first diagnosis of atrial fibrillation. But clinical skill set has to be, how do you do this rate control? When do you trigger your methods for rhythm control? And what are our options of trying to maintain sinus rhythm? So rate control, essentially everyone. Rate control, you'll try AV nodal blocking agents, and then you check and see, are there symptoms related to the arrhythmia? When they are in arrhythmia, they have symptoms, usually palpitations, maybe fatigue, that go away when they are not in the arrhythmia. Despite your best attempts at rate control, that's when you start thinking, how am I going to maintain sinus rhythm? Small caveat is, even if they are asymptomatic, but if rates continue to be high and that's affecting ventricular function, even in the absence of symptoms, you've got to do something more, and usually the next step there is rhythm control. But rhythm control doesn't work many times, and if that doesn't work, you may have to shift back to a more aggressive rate control strategy, maybe AV nodal ablation. Rate control agent choice, it really is the company that it keeps. So it's more like how you make a decision between beta blockers, calcium channel blockers, for anything else, for hypertension, for other arrhythmias. Heart failure, already a reason for a beta blocker, then you titrate the beta blocker best you can to achieve rhythm control. Contraindication to a beta blocker, maybe you'll try a calcium channel blocker. Word about digoxin for rate control. Digoxin is easily overwhelmed when there is sympathetic activity. So even the remotely active patient, as a standalone drug, it's no good. So could be an adjunct, better in patients who just don't do that much anyway. Elderly, nursing home type patient want to control the rates. Word about amiodarone, it's not a rate control strategy. Unless you have a really good malpractice lawyer, don't use amiodarone for rate control. By the way, if you're justified in a rhythm control strategy, it's pretty good at managing rates for breakthrough arrhythmias, but should not be thought of as a sole rate controlling agent. What is rate control? So used to be, we were much more aggressive, used to have this 80 average rate based on some early studies. Turns out both cardiomyopathy and symptoms, they don't correlate very well with rate anywhere in the less than 110 beats per minute. So it's become much more about symptoms than it is a target rate. Many times you will need to get that average rate less than 80. Sometimes you don't have to be that particular, especially when there's a trade-off from symptoms from the drug itself. So just like our decisions for treatment, decision for how aggressive you'll be with treatment, it's about assessing patients' symptoms. If they feel better, but the number doesn't look great, ventricular function's okay, it's okay. Some patients who have symptoms mainly with exercise, rate control at rest, even average rate with a Holter on a day they're not that active, may look okay. Just assess for the situation that provokes the symptoms. Look at their rates when they get the symptoms, like with a stress test, or when they're having the Holter monitor, ask them to do the stuff that brings out their symptoms. Walking on a treadmill, something that they were doing that predictably brings about the symptoms. Now, if you decide, I've tried the rate control, still there are symptoms, and I'm pretty convinced clinically that the symptoms are related to the arrhythmia, then you have to start thinking about how am I going to do rhythm control. First is to remind patients that rate controlling agents are not rhythm controlling agents. So you have to tell them up front from day one, the drug I'm starting you with will help control the rates, hopefully make you feel better, but how many ever episodes of arrhythmia you are destined to have, you're going to have them with the beta blocker or the calcium channel blocker. Now you're transitioning to really trying to decrease the number of those episodes. And that's going to be a membrane-active anti-arrhythmic drug, or it's going to be ablation. So how do you choose? So most patients will have at least one attempt at cardioversion. Usually we tell our patients cardioversion is not curing atrial fibrillation. It's a question of how long it's going to be before your next recurrence. If the recurrences are already happening, rate control is not effective. Now your clinician instincts, your decision making is going to be, what's my thought process in choosing an anti-arrhythmic drug, and what's my trigger for referring for ablation? So it's pretty simple type of algorithm, partly because we don't have many drugs to choose from, and partly because the main question you'll ask is, does the patient have structural heart disease? And what that means is depressed ventricular function or coronary disease with or without, especially with a myocardial infarction. If the answer is no, you have lots of choices. The bad choice is amiodarone, not because it's not going to work in that patient population, is you want to try something that's less likely to produce long-term toxicity. And you have choices. Sodium channel blockers, most common, flecainide and propafenone. Potassium channel blockers, most commonly used, sotalol and dofetilide. All our choices, typically you'll start with flecainide or propafenone. Now, if you've done this, and then you have a situation where you still have symptomatic arrhythmia. Remember, our whole story of treating atrial fibrillation is symptoms, making patients feel better. So rate control, you tried, still symptoms. Rhythm control, you tried, still symptoms. What to do? Here, if it's paroxysmal atrial fibrillation, this would be a classic indication to proceed with ablation. Now, on the other hand, if you have a patient with structural heart disease, here you don't want to use flecainide propafenone. And the reason is not that it doesn't work any better in this patient population, it works about the same, but it's pro-arrhythmia, ventricular tachycardia. The way these drugs work is they slow conduction, may be a good thing in the atrium for atrial fibrillation, bad thing in the diseased heart because it'll promote ventricular tachycardia. So you don't use it with low EF prior MI. In those patients, we still can try a potassium channel blocker. Doesn't work, you have an option of amiodarone. And with amiodarone, because of its side effect profile, a lot of patient education, and you have to really be convinced that these symptoms are worth treating with a drug like amiodarone. Ablation is an option for failure of drugs in these patients. One word about dronedarone. It's one of those drugs that has more contraindications than indications. So if I say for a general cardiologist, don't use it. So if you have no structural heart disease, you have some experience, comfortable with using drugs like flecainide or propafenone, by all means worth trying. Structural heart disease, sotalol, dofetilide, in some patients, amiodarone. So if we think about now who you're referring for ablation, patients have heard about it, you've heard about it, comes up as a question, and as a clinician, you should be clear on what does ablation help with, what doesn't it help with, and what are some of the complications that will present to you as a referring provider. So first, paroxysmal, symptomatic paroxysmal atrial fibrillation. That's what I like getting up in the morning to do, because you really feel you have a good chance of helping this patient. Persistent, long-standing, persistent forms of atrial fibrillation, we help, but not as much. So your threshold is higher. Should be convinced you've tried some drugs. You should be convinced that these symptoms are attributable to atrial fibrillation, and it's affecting the patient's lifestyle enough, and the patient understands, has realistic expectations of the procedure, may still need medication, we're going to try to reduce the number of episodes, then it's worth doing. What is this ablation for atrial fibrillation? So atrial fibrillation ablation, when patients ask you about it, it's generally identifying sites that trigger, initiate the arrhythmia. This is the standard, most common procedure for atrial fibrillation ablation. Where does this atrial fibrillation start? It's like in the midst of this chaos, backtracking and seeing where did it begin that started this atrial fibrillation. And most of you are aware of this story. The trigger, the start for atrial fibrillation is rarely in the atrium. It's in some neighbor of the atrium. Very often, maybe 70% in the pulmonary veins. Somehow, the muscle sleeves, some of the little cell rests, node-like cells, sometimes even the smooth muscle of these veins can cause rapid firing that triggers, initiates, maybe even maintains atrial fibrillation. So this gave the target for atrial fibrillation, and it's the pulmonary vein. It turns out that this ablation procedure is essentially never a cure. Maybe occasional cases, but you present this as a control strategy. Some patients have no symptomatic episodes. Many will have some asymptomatic episodes, but the idea is, do symptoms improve? And do symptoms improve? The answer is yes. Rule of thumb, somewhere between 50 to 75% of patients who have a single ablation procedure will feel that their symptoms improved significantly. More for paroxysmal atrial fibrillation, less for more permanent or long-standing persistent forms of atrial fibrillation. The actual ablation that's done is not in the pulmonary veins. And the reason for this is when you burn inside the pulmonary vein, it tends to scar and stenose. So the idea is to try to cage the pulmonary veins, to do like a big circle of ablations that electrically isolate the pulmonary veins from the atria. So this is probably part of the reason why success rates are not good. It's just like if I told you there's a man-eating tiger walking around in your midst, and I asked you, which would you rather do? Shoot the tiger or cage the tiger and keep talking around it? You'd probably prefer, I know there's some animal activist here, but you'd probably prefer shoot the tiger. And we'd love to do that in the pulmonary vein, but the stenosis is extremely scary, especially those of us who were in the early days of doing AF ablation. It's a horrible, horrible condition that you need to try to avoid. So you accept some recurrence, but we want to avoid this pulmonary vein stenosis. Few things about ablation. Very important that patients should understand you are not ablating to prevent stroke. Absolutely no data that you change the risk profile for stroke with ablation for atrial fibrillation. It's a symptom-directed therapy. If a patient is asymptomatic, their ventricular function is fine, they have no indication for ablation. You don't do it to reduce stroke risk. You definitely don't do it to save life. This is unfortunate, but you'll see some billboards in the United States. I saw one actually driving to Jacksonville that says, you're going to die if you don't get an ablation for atrial fibrillation. Absolute mistake to think that way. There's really no good data to support that. Now, one of the criticisms of the rate rhythm control type strategy, rhythm control versus ablation strategies was, they were all done when ablation wasn't very good. So a more recent look, very nice study, all of you are aware, was to try to look, especially for like major endpoints, all-cause mortality, stroke, serious bleeding, out-of-hospital cardiac arrest. Is it better to just ablate up front rather than give a trial of drugs? Very good question to ask, because ablation has come a long way, and some drugs kill people. Torsade from the drug. It's an important study. Bottom line, when you look intention to treat, it really was no difference. So you cannot justify ablation as a strong endpoint like disabling stroke, like looking at cardiac arrest, all-cause mortality. We still think about symptoms as the driver. And if we look also at drug versus ablation, just mortality, there's no difference. Now, there are some pointers. If you look at just the people who actually got the therapies, and especially in some subsets like heart failure, that there does appear to be a benefit from ablation. So it's enough of a signal for when we make the big next step in better ablation, or we have comparative study, that there may be sets of patients that there genuinely is a mortality benefit, but these are only signals. So cannot use these to counsel your patients at this time. Role of surgical procedures for atrial fibrillation, main issue is think about it if there is another surgery being done, like open mitral valve surgery, where you have another indication, patient has atrial fibrillation, could think of as a class 2A indication, a surgical MAYS procedure. At present, the value of limited MAYSes, thoracoscopic MAYS procedures, hybrid procedures, is unknown. The data is weak, and it's an area of investigation. You already had a talk about anticoagulants. I'll just touch some high points. First thing is the risk of stroke with atrial fibrillation is a fact. The pathophysiology of this association is unknown. So it used to be the thought that someone goes into AFib, blood swirls around, you get a clot, you get back to normal, the blood clot goes to the brain, you get a stroke. That's part of the story. It's not the whole story. If you are young and have a normal heart and you have the same AFib as a diabetic, coronary disease, ventricular dysfunction patient, your stroke risk is much less. Studies with implantable pacemakers proved there is a relationship of AFib plus stroke, but 90% of the stroke events occurred on a day the patient didn't even have atrial fibrillation. So in many ways, this is an epiphenomenon, an association where we don't really understand the equations for risk and benefit. The way I tell patients sometimes is atrial fibrillation and stroke, they're a little bit like gray hair and wrinkled skin. And my apologies to the doctor here, but gray hair and wrinkled skin, they go together. Folks who have one tend to have the other, but if you color the hair, the wrinkles won't go away. So same way, AFib and stroke, they're there, but best as we can tell, our best treatments for AFib, they don't make the stroke risk go away. That's why we still risk stratify the way that you heard earlier. Main is using the CHADS VASC score, little different from before, mainly in splitting up the age categories you're aware of, and the issue that if you're a woman, especially above the age of 65, there is a higher risk that makes it worthwhile. Main advantage of this scoring system to me, clinically, is I'm happier when it's 0. Because unlike previous scoring system, there was a still troublesome incidence of stroke. Here, when it's 0, you feel a little bit more happy and more comfortable with using this system. You have to factor in bleeding, though. You cannot go in with just stroke risk. It's always going to be judgment. You can never give a cookie-cutter approach. You have to think about individual patient risks, and you have to factor in previous known bleeding and risk of bleeding to make a decision. But by and large, anybody with structural heart disease and atrial fibrillation, mechanical valve, mitral stenosis, probably hypertrophic cardiomyopathy, you will use anticoagulation. Otherwise, a normalish heart, you're going to go scoring system. And if your score is 2 men, 3 with adding the gender score, for women, it will be anticoagulation. And like you heard, the choice, it's really a choice, warfarin or a newer agent. Newer agents, each of them when compared, did better in terms of major bleeding, almost across the board did better with intracranial hemorrhage, but you have to balance with cost, you have to balance with patient preference, how well they've already been doing with warfarin, and by and large, I offer it as a choice to most patients. Brief word about patients, clear stroke risk, but can't tolerate an anticoagulant, then appendage management is the option. The one that's the most experienced is appendage closure endovascularly, gaining experience with epicardial approaches and surgical approaches. From what's known with endocardial approaches, it's about as good as warfarin. Maybe a little bit different in terms of type of complication, type of bleeding, when it happens. But overall, it is an option when you know that you are not happy with long-term anticoagulation. You're okay with using it for a short time after the device has been placed in. Don't forget one of our most powerful antiarrhythmic drugs, and that's lifestyle. Diet, exercise, and weight loss. We used to like saying it just because we like to make our patients feel bad about themselves, but now there is clear data, probably for about 10 years now, First data that came is post-ablation recurrence, post-drug recurrence. If you did aggressive lifestyle changes, actually got the weight loss, actually got a reasonable amount of aerobic exercise, your recurrence was less. If you just take, even without a specific therapy, atrial fibrillation, there's benefit as well. Some would say the benefit is not that different from ablation. I think that's a little bit of a stretch, but it's certainly something with benefit that should be part of any AFib management program. It's no longer enough to just tell patients. You really has to be part of how you monitor a drug, how you work up for other procedures, part of that picture. What presents to you as complications after AF ablation? You should be aware of these. First, patient feels great after ablation. Arrhythmia is better, goes home, and then you get the call, I feel short of breath, especially when I lie down. Think about phrenic nerve injury. So sometimes when we ablate near the superior vena cava, right upper pulmonary vein, we can injure the phrenic nerve. Easy to diagnose, you can do it clinically, X-ray, sniff test, you'll see it. Fortunately, the majority get better in about 6 months. The few that don't are helped with plication of the diaphragm and weight loss. Their symptoms can improve, but fortunately, most of them you say, sit tight for 6 months, hopefully it'll go away. Another very important one that will present to you is pulmonary vein stenosis. Unfortunately, this still happens. Usually it's folks a little earlier in their career, but can happen with anybody. What happens is, inadvertently, energy has been delivered inside the pulmonary vein and it scars. How do these patients present? It's cough, but could be fatigue, could be hemoptysis, could be exertional dyspnea. Any of these, you should think about this syndrome, especially the patient who starts getting the symptoms about a month after ablation. And they will present to you. I've had patients with this complication who've even had lung biopsies looking for atypical actinomycetes, and no one thought about this possibility. So it should be high in your thinking, dyspnea after ablation. And you can fix it by stenting the vein. Sometimes you have to redo it because of restenosis. Not easy to manage, but manageable, and patients do improve. Main reason for trying to make this diagnosis. Very, very important thing to know about post-ablation. Patient presents, says, I'm having little trouble swallowing and I was fine after the ablation. I'm having TIAs, I'm having fevers, endocarditis picture. This is a life-threatening complication, and that is atrial esophageal fistula. The body literally eats its way to the heart. After ablation, you get an ulcer. Acid digs the ulcer, burrows through the oblique sinus of the pericardium, and goes into the heart, producing a fistula between the left atrium and the esophagus. Doesn't happen right after the procedure. Typically going to be 4 to 6 weeks, as late as 3 months after an ablation occurs. Symptoms should be the clue to you. Anything funny happening after that period of time, this should be your working diagnosis. And the treatment is surgery. Very, very important that surgery is done early. As soon as you suspect it, the story fits, the patient should have surgery separating the atrium from the esophagus. Many techniques to do it, but it must be done. If you don't do it, the patient will die. There's a handful who've done okay with some kind of stenting procedure, but many more who have died with attempts to try to manage this conservatively. Surgeons will balk. They'll say, you don't know what you're talking about. This is not what Boerhaave syndrome looks like. When they give you a hard time, I'll give you my cell phone. Call me. I'll give them a harder time. Sometimes it's not esophageal trauma, it's the vagus and its branches in front of the esophagus that get damaged. This is not so bad. It's bad symptoms, gastric emptying syndromes, stasis in the stomach, but again goes away. Very, very few patients this is permanent, typically goes away in about 3 months. Sometimes drugs like erythromycin, metoclopramide can improve some of this gastric emptying, but can be pretty severe. They've had patients who've had lavages after this. Something they ate 7 days ago was still inside their stomach. So it can be pretty severe, but fortunately does go away. Stroke, unfortunately, with ablation is an issue. Some new methods of trying to decrease this by the way the catheters are coated. New kid on the block is an energy source where you don't have to heat or cool the tissue to ablate. It's a non-thermal method of ablation, has to do with placing an electrical field, tremendous amount of increase because takes away these blood clot formation, esophageal injury, nerve injury, probably with this type of ablation. Another new kid on the block is non-invasive ablation, mostly being used for VT now, but some very encouraging animal studies for atrial fibrillation. It's just like radiation therapy for cancer. You map out your field, do this. This was in a beating heart in a pig, that you can do the energy delivery, heavy particle ablation to create these same types of lesion sets. Still heating the tissue, but nice thing is you take away the stuff of putting in catheters and some of the risks with that therapy. Modulators for atrial fibrillation. Question you could ask is, if pulmonary vein triggers the atrium, what triggers the pulmonary vein? And it turns out atrial fibrillation, paroxysmal in a large number of patients, is probably a form of autonomic epilepsy. It's very rapid firing that you can recognize in the neural tissue before you see the changes in the pulmonary vein and atrium. So that's what we should ablate. Sure, except this is what the neural tissue coming to the heart looks like. Tough to do. But what's not so tough to do is where they converge. And they converge in the ganglia behind the atrium. Much more discrete than this quagmire of nerves coming in. And some investigational approaches, surgical and catheter-based, that look at this. Just a word, you'll hear about these neural stimulatory, non-invasive methods for treating atrial fibrillation. So these have to do with stimulation. These could be devices put far away from the heart, including in the pelvis, developed by an orthopedic surgeon of all people to try and change the autonomic tone for atrial fibrillation. Some are much simpler. They're like little things you can plug onto your tragus. There's even an integrated headphone where you can put this little plug while you're listening to music. So when that hallelujah chorus comes out, there'll also be a stimulatory sequence that will make atrial fibrillation less likely to occur. And attracted a tremendous amount of attention from some studies, mostly from Oklahoma City, now taken up by some of the major headphone manufacturing companies to see, can we modulate the amount of atrial fibrillation? So clinical decision-making, atrial fibrillation. Remember rate and rhythm control, it's all about symptoms. Start with rate control, not too hard to pick a drug, titrate the drug, you already know how to do it. Doesn't work, still symptoms or ventricular dysfunction, rhythm control strategies. Remember, it's about structural heart disease and symptoms. Symptoms, paroxysmal, no structural heart disease. Usually, flecainide propafenone doesn't work ablation. More persistent, be sure that you think the symptoms are from the disease. Think about next line drugs, potassium channel blockers, maybe amiodarone, ablation as part of the picture to minimize the patient's symptoms. Remember that you don't do ablation to minimize stroke risk. No data to support this, certainly not to save lives. Remember that some of the newer approaches, autonomic modulation, new ablation strategies, hold some promise to getting a little closer to where we can say we have something closely resembling a cure for atrial fibrillation. It'll probably be the same day we also cure gray hair, wrinkles, balding, and age really becomes a number. But we'll get there. Thank you very much for your attention.